Okay, good morning. Thanks, Mike, Adam, thanks for having me. Paul, Subhash, organizers. Another great meeting, as everybody's noted. So, as you heard, Paul's been very creative, very thoughtful, and he's got this integration of mesh pieces of nothing is close. So maybe we'll get a slide. They said you can't eliminate this one. Yeah. But anyway, so some of the same topics and some of the creative thought about where we've been, where we're going, what's innovation, and just the use of the name of the meeting. So he asked me about deficiencies in TAVR science and where do we need to go. We actually saw a lot of that this morning in various and sundry forums, and everybody did a great job of covering it. Here are the disclosures. I put in a slide real quickly that just emulating Samir and imitation, the greatest form of flattery. We talked about what's different, what's changed, and where are the deficiencies. Well, these are the places where there really probably aren't the deficiencies anymore. Learn it from Samir, try to get our partners to adapt it. They haven't fully embraced it yet, but we went to one ProGlide closure, and what it does is he talked about it eliminates the narrowing of the artery, and as long as you don't have bleeding or screw it up, everything else works. I will tell you that if you've done a lot of ProGlide and you're pretty good at it, you feel comfortable with that, but also if you have a training program and you got fellows and you got a bunch of partners who are doing it, and you have somebody break one ProGlide and you don't have any ProGlides left, you get really distressed. So my modification of that is now we put 2 ProGlides in, waste a little bit of money, but we put them in at 12 o'clock. And one of them's just insurance. And as Samir said, we use Angel Steel. But this is certainly changed even a bigger depth of the access problems as we've gotten smaller. We're in Texas, so fracking is also new. Efficiency, this is not all that new, but the mantra to our anesthesiologists is we're done with 3 cases by noon and they're supposed to be on a golf course. We actually try to do 4 by 1:30. Same day discharge. Sounds a little crazy, it's all the things as Samir said. You don't want to diminish reimbursement, but that's not our biggest problem. And our biggest problem is that we know if we keep people in the hospital, we make them sick, and we can even kill them if we try hard enough. So some of you have seen my video of World War II veteran, 88 years old, who had a case 11:30, went home at 5 o'clock. That was more of an accident because we didn't have any beds. However, we do now have a protocol. We have same-day discharge, and we're looking at that. And then neuroprotection is clearly here. It's new for us, and we're part of a couple of the trials, so we're going to see how that plays out, but it's new. So this is going to go quickly, but low risk, intermediate risk, high risk, perhaps. We've used Vino's slide that he extracted from the database with almost 150,000 patients multiple times. You've seen this, you know it, but embedded in your head, is it 20% are high risk and intermediate risk? 80% aren't, but high risk and intermediate risk and partner and Versatility and other things is really a pretty good settled science. With 2 cardiologists sitting up here, and one cardiologist and one surgeon. The surgeon is probably the biggest prototype. Mike's often debated me with, this is TAVR, and it's important, and Mike's the prototype of that. So we know that there are plenty of these people you don't want to operate on. So where are we? Well, we're really in the low-risk journey, and we're waiting for this data, that Bill and everybody talked about earlier. So if we look at this, it's really probably an unsettled science in low-risk patients. And where are we? I'm going to say this is a composite of some of the issues without getting too cute about technology and Zeltis that we'll mention, as Mike and others pointed out this morning. But neuroprotection, durability, leaflet immobility, or valve thrombosis, and perhaps the permanent pacemaker rate. Some others, vascular access, as we saw, is going away fundamentally. Coronary obstruction, you got a great lecture on that and the pieces and parts of it. And then imaging, we'll just touch on that briefly. So neuroprotection, much of this stroke rate from early days, from the most difficult patients, from literally inoperable patients who were done, who probably shouldn't have been done, and partner on into Versatility. As we go down through intermediate risk and low risk, the rates continue to go down. Sentinel trial, you heard about it again already today. Certainly the aspects of, you got a negative trial, not so fast, because, as pointed out, endpoints may not be right, and what do we know? We know that the devices were safe. There was a significant reduction in sort of mental state, cognitive, delirium pieces, and there is a reduction in lesion volume, and we'll touch on that in a minute with a family tie. But Whenever you take these devices out, we virtually always have something in there. You have to look hard sometimes, but there is debris in there. There's something in there. You can say, well, it's small. I'll let that go to my brain. Probably not if it was your brain. CTSN trial, same kind of thing. All these things are building data, and I think we're going to see, as this accumulates over time, we're going to see a lot of data moving towards neuroprotection is sort of the crucial element, as the FDA has already recognized. Again, a trend and some data showing it. So will it become the standard of care? I think so, and we talk often about the fact that it may become the standard of care beyond TAVR and other surgical realms. Would you want it for your mother, father, grandmother, or yourself? Mike and I talk about this a lot. We spent a lifetime trying to figure out what to do to somebody based on what we would do to each other. And we also always ask our hospital president, would he want one, or does he just want us to not pay for it? So this is what it's going to look like, right? In the black without neuroprotection right now, it will get reimbursed. What's the add-on going to look like? Nobody knows, but I think you're going to see neuroprotection. Durability, again, everybody touched on it. Early days, all the trials, out to 5 years, very durable no matter which measure you really use. Partner, core valve, all the things. This is a partner trial, Mike, Marty, the entire partner gang. We know that the outcomes go that way. No reoperation or structural valve deterioration, now well past 5 years. And everybody's favorite, Mike's Journal of Biomechanics that you study, measuring stress and strain, but what it shows on the left are different strains on TAVR and SAVR valves. And fundamentally, what they said is the simulation suggests that the durability of TAVR valves may be less than SAVR, maybe down to under 8 years. And then the Stanford group looked at mechanical versus biological, looked at the probability of mortality in the view of these different valves. And also on the right, you can see that fundamentally they've tried to answer the question of the debate of what age is the right age, where do you switch, where do you change, where do you come down, and we've seen it happen from, a good while ago, 70, 65, 60, into the 50s, and what's the right answer? Partner trial, along with all the other trials you saw this morning, we're seeing that everything is going to be followed through 10 years, so durability is going to be looked at, I think, in very good ways, and you're going to see, we've already seen extension of some of the 5-year follow-ups to 10 years. It wouldn't be surprising to see some of the 10-year trials to get extended to 15 years or more. Valve thrombosis, came on the scene. Raj did a great job of the initial presentations and the awakening. Again, all the work out of the Scandinavians and, part of the whole partner group. Lastinger and Shurin certainly reflected on it from the FDA, and then Mike and David wrote the very nice editorial in the New England Journal. You've seen plenty of these pictures probably by now. We see them in all valves, core valve, portico, sapien, but also surgical valves. And you can see the accumulation. We have a phenomenal imaging specialist. He brings these pictures up to us so you can see virtually every aspect of it happening. 30 days post-TAVR, asymptomatic, a gradient change, but 12, not a 20. And then post-Coumadin, we know that these things can generally be dissolved. SAVR, same thing, clot forming, affecting leaflet function, and we see it across the board. When we look at it in TAVR, a study showing at 7%, some have shown maybe above that. What we've seen in this, again, from the Resolve and Savory investigators is it's more common in TAVR, 5 versus 13% perhaps. DAP doesn't work, anticoagulation does. There is an increased association with neuro events, and this has the opportunity to improve things with treatment and prevention. So permanent pacemaker rates imaging and new technology. We saw a little bit of new technology. I'm not going to really go into new technology because it's rapidly changing. No matter how young or old you are, if you've been here paying attention for the past 5, 10, 15, 20, or 30 years, new technology has taken over just about everything. Permanent pacemaker rates, all comers, impacted by age. Don't forget who we started with in the very elderly. Average age in the first trial is 86. Risk scores, conduction system disease that they already had. Maybe we just forced them to expose that whenever we gave TAVR. So if you look at high risk or low risk only, does that start to change? Right now, there's a multiplicity of data, multiplicity of trials, multiplicity of different rates with different valves. but it looks like that, probably you could get everybody to agree that TAVR's above 10%, and then you can parse it out in those things, and that SAVR in good surgeons' hands should be 4%, 3%, maybe a little bit less. And where will the low-risk PPM rates settle out for TAVR? We think that they'll come down, but the data's still out there. However, there are other things that are happening as well. On the technology side, the leadless pacemaker now, Micra, NanoStem, the companies are going to have leadless pacemakers. You don't have leads lying across the tricuspid valve. There's still going to be issues about long-term pacing in people who are younger, but these things are going to change with technology as well. And we're going to see a lot of things on the horizon for all these parts and pieces, whether it's vascular access, pacing, or the technology of the valves. Here is a leadless, non-cardiac, non-vascular pacer. Okay, so instead of getting a median sternotomy in your midline, you get a little nick that looks like a link, and you lay a pacemaker on top of your sternum. Some of these things may alter, what happens as these things try to come together. Imaging techniques, if you have a great imager like we do, 3D modeling, 4D CT, and some of the parts and pieces, both for sizing, valve evaluation that we haven't even dreamed up yet. New technology, as everybody touched on in various ways. Multiple valves and trials development in 6 continents. I don't think there are any in Antarctica. Multiple new design technologies, and the new materials touched on by a couple people, including my partner Mike, ETR and Zeltis. So is this low-risk TAVR? Probably not, but fundamentally the issue is, okay, on the left, neuroprotection fails, isn't reimbursed, TAVR durability doesn't work out, low-risk patients on anticoagulation, how long, what happens, what are the complications of Coumadin et al. TAVR pacemaker rates remain disparate, get more disparate, or neuroprotection works, gets paid for, TAVR is durable, it lasts as long as SAVR, valve thrombosis, false alarm, SAVR and TAVR rates, pacemaker-wise, no difference, and Dr. Reardon finishes up on the wave. Thank you very much.
David, that was a great setup for where we are now and where we need to be. Is Chris Midori here to talk about the revolution? Maybe he's getting dressed in his Prince outfit.
Well,
Maybe not.
Let's move on.
Okay. Okay, so let's move on to the science of sapien. Alan Zaharias.
Well, thank you everybody for coming this morning, and I actually don't know how to change this lecture, so there we go. There we go. Okay. So for the last 8 minutes, Paul had actually asked me to talk about the science of sapien. And when trying to figure out how to address this lecture, I figured I was going to talk a little bit about how we started and where we are now. So everything started on April 16th of 2002 when the first catheter valve replacement was performed successfully. And since then, for the last 16 years, we've actually been in part of the revolution of transcatheter valve replacement. And what we've seen in 16 years related to the balloon expandable sapien family of valves is that we have more than 7,300 patients treated in the United States in a research trial. We have more than 95 publications and others that are in press. And we have more than 100,000 patients treated commercially. So all in all, there is a fair amount of data that we've actually been able to extrapolate from the history and hopefully try to predict what's going to happen in the near future. So it all started with the Cribier valve that then clearly transformed into the sapien valve for the PARTNER 1 set of trials, then the sapien XT for the PARTNER 2A, 2B trial, and then finally the sapien 3 valve, which was placed in the intermediate risk category and in the low risk trial. And each step of engineering changes has actually led to the outcomes that we previously heard from Dr. Brown. And the first thing that we changed was the balloon. The first TAVR in a balloon expandable valve was actually mounted on a balloon that was non-proprietary. It was crimped right then and there without any evidence of markings or things of that nature. And with that, there was a lot of variability in the positioning and in the deployment. So the first big step, since we do not have the ability to reposition the valve, was to make sure we have a very exact and precise mechanism that is easily reproducible in trying to deploy these valves. And as a result, Edwards came back with a balloon that was volumetrically sized, and the vents were actually changed in their position. And as a result, the balloon was able to expand more predictably. And as a result, you were able to have appropriate inflation pattern and a very appropriate sizing, which would then lead to less complications. The next thing that changed was the delivery system. Once again, we started with a stiff catheter that had a small amount of angulation to it, but no nose cone, which made it very difficult to traverse the aortic valve. And then from the different modifications, from the Retroflex, Retroflex 3, NovaFlex, to finally the commander system that we all currently use and are actually very pampered with, we're now able to treat and travel through pretty much any vessel tortuosity, angulation across the aortic, the ascending aorta, and difficult aortic arches. All of this while maintaining the coaxiality of the valve, which then would lead to an increased number of the patients that we can treat and treat safely. In addition, hopefully by decreasing the amount of scraping that we get within the aortic arch, and as the change in the diameter of the catheters happen, we basically will decrease the amount of strokes as we have seen before. So all in all, these technological advancements have actually allowed us to travel across the aortic arch, cross the valve more safely, and maintain coaxiality to have a predictable deployment. The next big step was the sheath. We started with a very stiff, hard sheath that then transitioned over to the expandable sheath that we're all familiar with. And for all of us, for all the fellows and for all the younger practitioners who are only familiar with the expandable sheaths, it's a pretty big difference. You'll see there's actually something coming down in the pipeline that is even more exciting than our E-Sheath 2 that we currently use. And what started as a 24 French system, which now finishes at a 14 French system, is actually quite remarkable, as you can remember. However, the biggest iterations also happened within the valve per se. We went from a balloon expandable valve that was made out of stainless steel to one valve that was made out of cobalt chromium. It appeared to be somewhat smaller with wider cells. This actually allowed to have the same amount of radial strength while maintaining the appropriate circularity of the valve. In addition, the leaflets changed in order to make sure that they would potentially enhance durability and improve their form. And then from there, we moved on to the SAPIEN 3 system, where once again, there was one more big iteration. There was now different cells designs. There's both large cells in the top and bottom cells and smaller cells in the bottom that basically allow for a very predictable deployment and non-movable or non-movement of the valve. As a result, you have appropriate radial strength in addition to appropriate coronary access if you ever need to address it in the future as we begin to tackle lower risk patients. And then the idea of the outer skirt became very useful in order to minimize the amount of perivalvular insufficiency, which was thought to be one of the largest Achilles heels in the catheter valve procedures. As you can see here, when we deployed a SAPIEN XT valve, there was very little predictability on how the balloon was going to expand. Well, if you can see on the other side, how you basically expand a SAPIEN 3 valve where there's relatively no movement whatsoever as the valve is deployed. And all of this happened because of the combination of the delivery system, the change in the balloon, and the change in the cell design. And as a result, now we have a highly predictable platform that avoids us from having valve regret. Now, from a durability perspective, we've seen the data from Dr. Mack et al. From the partner trial, where we have documented durability of more than 5 years, both with an appropriate hemodynamic profile and an appropriate valve area. The other thing that we've seen within all of the partner family of trials is that in the extreme risk and the inoperable patients, transcatheter valve replacement saves lives, prevents hospitalizations, and prevents heart failure. And as a result, it's better than medical therapy. In the high-risk individuals, they're non-inferior to surgical valve replacement in the primary endpoint of death and stroke, with a potential slight advantage in the lower-risk individuals, as you can see further. And finally, in the intermediate risk patients, you'll see that there's, once again, non-inferiority from a perspective of SAVR versus TAVR. However, in the transfemoral cohort, there is definitely suggestion that there could be a survival advantage from the transcatheter valve replacement. All in all, you can see that the vascular complications are not necessarily insignificant, but they're much lower today than what they were when we started. And the pacemaker rate is still numerically larger than SAVR, which is something we always have to keep in the back of our minds. When you see the data from, that was published by Vino from the SAPIEN 3 intermediate risk, you once again can clearly see that there's a firm survival difference or an avoidance of mortality within the TAVR valves as compared to the SAVR valves, which is something that is very remarkable. And as can see here in a slide that was previously shown as well, you'll see that the mortality of the patients has decreased dramatically as we begin to tackle lower risk patients, but also in the same patient subset that were considered previously inoperable or high risk. And in all honesty, in order to maintain a 30-day mortality of 2% or of 1.1%, that leads to all of what we've actually learned from the previous experiences on patient selection and the procedural refinement. Vascular complications have dropped dramatically. As you'll see, we started with 16% with the 24 French delivery system, and now with the data that was presented at EuroPCR by Dr. Touchou, you could see that even in the commercial setting with the TVT registry, for all comers, there's a 4% rate of vascular complications, which is once again very remarkable considering this started in a very sub-selected group of institutions and now is pretty much disseminated throughout the United States. The stroke rate continues to decline, which is questionable. Definitely the clinical stroke rate is lower. However, the neurological or the radiological stroke rate is very different. And I think here's where we're going to see the majority of the advances or the changes that will happen over the next 2 to 3 years. We've learned that conduction abnormalities are not necessarily inconsequential. However, in the high-risk individuals, it appears that they're not as dramatic as they are in intermediate-risk patients, particularly because of their overall survival. However, we'll see if this still continues to become an issue in the lower-risk patients as we continue to evaluate them in follow-up. The versatility of the valve also is very helpful. As you can see, we can treat now native aortic valve stenosis, degenerative bioprosthetic valves quite safely, pulmonic prosthesis also quite safely, and now the mitral prosthesis, all within the same valve. So the SAPIEN balloon expandable family of valves actually allows you to have that versatility, which is something that is pretty much unequal to any other valve. But where do we go from now? So Partner 3 is closed, so the low-risk individuals are now officially or can be treated with transcatheter valve replacement. They'll continue to be followed up, but the continued access registry that will enroll 2,000 patients is up and running. There's an underrepresented population registry, which is important. The bicuspid registry is now closed and is in follow-up, at least with these 75 patients. And then the aortic valve-in-valve for low risk and intermediate risk, and the mitral valve-in-valve registry for intermediate risk patients is actually up and running. But importantly, we need to make sure that we know what happens to patients who develop a failed bioprosthetic valve. What happens to the TAVR that's failed? We've all treated them, but we've not necessarily systematically analyzed them. So this is a plea for patients to be enrolled in the valve-in-valve registry for a failed bioprosthetic valve, a failed TAVR valve if possible. Early TAVR is coming, so we're trying to see if patients should be treated if they have asymptomatic severe aortic stenosis with a long-term follow-up, and whether or not there's a biomarker predictability of who would benefit more from this procedure if this becomes appropriate. TAVR and load is also very exciting. It treats patients with moderate AS and LV dysfunction. This also will change the paradigm on how we approach patients with heart failure if this happens to be a positive trial. So more to come on this as well. And finally, this is a slide from Raj Makkar that I borrowed, but he presented matched data on TAVR and bicuspid valves, and they got matched to patients with a tri-leaflet valve. And notice that there's the rates of aortic insufficiency appear to be very similar, which once again can lead to better selection and better availability for this type of technology in this patient subset that has not been treated so far as diligently as what we have with a tri-leaflet valve. As far as device innovation goes, the Axella sheath is the next generation sheath that we'll have. So E-sheath will be out, Axella will be in. We know that this is a seamless expandable sheath, which has an elastic layer that actively contracts after it expands when the valve goes through. So that's very exciting, and it appears that all the prosthetics will now fit through the 14 French size as opposed to needing a 16 French sheath. The Ultra delivery system is a next generation commander system in which you won't necessarily have to lock or unlock the device, but more importantly, the valve will actually be mounted on the balloon when you start, which then will make the procedure a little more seamless and potentially faster. And then in addition to that, there's a responsive articulation that will allow you to traverse multiple tortuosities. And finally, SAPIEN Ultra, which actually has the same stent design as was previously seen, but you'll see that there is actually a longer skirt that now which is 40% taller, and it's textured in order to help facilitate the coverage of paravalvular insufficiency. So we've gone from patients who have surgical risk from high, low, and high and intermediate and potentially low risk. But what I would potentially offer to you is the idea that surgical risk is not equal to procedural risk. And we'll definitely want to make sure that we evaluate patients' anatomy and then decide if TAVR is the way to go, if SAVR is the way to go, or how to address this. So let's forget about the STS 1 through 10 or 1 through 15 and hopefully try to focus on anatomically which are the patients who would likely benefit the most from one or the other procedures. These are the characteristics of the SAPIEN valve, and I can see that with the data that we have so far, that we've accumulated, we pretty much have answered and have generated a device that is simple to use, it's predictable, is versatile, has very low stroke rate, hopefully a lower pacemaker rate, and has significant areas to decrease vascular complications. Thank you.
Thank you, Alan. A couple comments as we move on. The bad news is a couple of our speakers didn't make it. Chris Maduri did a live case and couldn't make it back in time to talk about Evolute. It's too bad. The good news, we have Jeff Popma here. Jeff was the PI in all the core valve trials and was a thought leader in developing the Evolute valve. And the only comment I'll make on it right now is, Alan showed us the great results we see going forward with the SAPIEN family. Certavi was really a first generation trial, 84% classic. By continued access, it was 93% Evolute, and in 275 patients, 79 years old, there was 0 mortality at 30 days and 0.4%. So it's a little hint for both these valves of where we're going low risk. Danny DeVere couldn't make it either. Unfortunately, I didn't know about that either. I had the opportunity to run the Lotus trials with Ted, and I'm going to be the PI on the EDGE trial, but maybe at the discussion, if there's any questions, we can talk about that. Now, the good news is we're running really behind because nobody seems to understand the concept of 7 minutes. Me too. And by missing 2 talks, we're right back on time. We're now up to Dr. Michael Mack, and Michael's going to talk to us about valve centers of excellence, elitist or necessary. Thank you, Michael.
So you're saying the pressure's on not to get us behind again?
Pressure's on, Mike. We're watching you.
All right. The no disclosure slide takes at least a minute.
I know. You should reclaim your time.
So, valve centers of excellence, elitist or necessary? And this is my real disclosures. So the treatment of heart disease, valvular heart disease, is clearly changing. And you can argue whether it's for the better or for the worse, but it is clearly changing. If we look at decision-making in aortic valve disease in 1998, it was, do you want a tissue valve or do you want a mechanical valve? That has clearly changed. Decision-making for aortic valve disease in 2018 is not only tissue mechanical. Is it TAVR or SAVR? If it's TAVR, is it self-expanding or balloon expandable? Is the patient frail or not frail? Should they get a TAVR at all? Is the patient symptomatic or asymptomatic? Is it a bicuspid or a tricuspid valve? Is it, if a patient's got a degenerated valve in place, should it be valve in valve or a redo surgical aortic valve? And then what do you do about anticoagulation or antiplatelet therapy afterwards? Similarly with mitral valve disease in 1998, it was, you get a tissue valve or a mechanical valve. Currently, is it primary or secondary MR? Do you repair or replace? Again, is the patient frail? Do you do surgery or do you do a MitraClip? Do you do a transcatheter mitral valve replacement or surgery or guideline-directed medical therapy? Do you treat concomitant tricuspid regurgitation or not? Again, what do you do about anticoagulation? And then if you're going to go the transcatheter route, is it repair or replacement? And oh, by the way, the tricuspid valve, the so-called forgotten valve, is no longer forgotten with all of these treatment options. So the complexity has changed a lot over the last 20 years. This was valve imaging in 1998. Now, obviously, this is an oversimplification, but it brings out the point, this is valve imaging today. Clearly a higher degree of complexity than what was done 20 years ago in decision-making for valvular heart disease. So what do these numbers mean? 2,100, 1,150, 584, and 278. Well, 2,100 is the number of cath labs, 1,150 is the number of cardiac surgery programs, 584 is the number of TAVR programs, and 278 is the number of MitraClip programs. There was a day spent yesterday in Washington at what's called the MedCAC meeting, in which CMS is going to decide who should be doing what, when. So one of the proposals is a national system of care for valvular heart disease. And there are a number of examples of this that already exist for cancer, for trauma, for stroke, for bariatric surgery, and we all know for STEMIs. And there's different organizers of these, from the NIH to the American College of Surgeons to the Brain Attack Coalition to the ACC-AHA, with different tiers of care based upon what a center is capable of doing. And this is kind of how it's set up. So the NIH has cancer centers with 3 levels of care. There's 4 levels of trauma care in the United States. There's 3 levels of care for patients with acute stroke: a stroke-ready hospital, a primary stroke center, and a comprehensive stroke center for those that can intervene on acute strokes. There's bariatric centers of excellence, and we know that there's 2 levels of care for treatment of STEMIs. This is the stroke system of care, in that it's a cascading effect, tiered level of what level of care a center's able to give. Now, there is precedent for this in Europe, and this is published last year in the European Heart Journal about standards of what it takes to become a valve center in Europe. And at the minimum, you should have a heart valve clinic, multimodality imaging, a multidisciplinary heart team, and constant review of data. And these are the centers that a heart valve center should be able to perform. The principles behind it is that consideration of a volume-outcome relationship is complex, nuanced, and challenging. The ability to demonstrate good results is more important than mandating volume targets, and it is likely that good outcomes will not be attained without high individual surgeon and center volume for mitral valve surgery, and that large registries are expected to inform guidance on future volumes. And this year are the proposed standards for the treatment of mitral regurgitation in a center for surgery in Europe. Now, there's been a proposed expert consensus document for systems of care for valvular heart disease in the United States that was put out for public comment last year. The chairs of this writing group are Drs. Nishimura and O'Gara, and they received over 1,200 comments in the 30-day period that this was put out there. The 2 of them have spent the last year responding to these comments and revising the document based upon the feedback. The idea behind this is that the cost and complexity of diagnosis and treatment are increasing. It's not feasible for all cardiac centers to provide the full suite of resources, infrastructure, and expertise for the entire spectrum, and the guiding principle is to provide access to the right care at the right place at the right time while respecting a patient's preferences and values. And it's an idea of balancing quality with access to care. And how you strike that balance is very problematic, and again was discussed in eminent detail yesterday at CMS in Washington. So the idea behind this tiered system is that you would have a primary valve center and a comprehensive valve center, and there'd be a relationship between the primary valve centers and the more comprehensive valve centers, so that you have a tiered network of levels 1 and level 2 care. So a proposal for a level 2 care was that you would perform transfemoral TAVR, balloon valvuloplasty, surgical aortic valve replacement, and straightforward surgical mitral valve repair. And a comprehensive center would have the full suite of options available for the treatment of patients with complex valvular heart disease. So the principles, no matter what tier you would be, was that you would use a heart team with multidisciplinary approach, shared decision-making with clarity to the consumer, participation in national registries and research trials, participation in quality improvement initiatives, ongoing analysis of processes and outcomes, and transparency of outcomes by participation in public reporting of outcomes, and the ongoing education of the valve team as well as to the levels of referral. So how does all this add up? Should there be a national system of care for valvular heart disease? Well, the best initial system is probably a tiered system of valve centers. They need to have commitment to structure, processes, and outcomes. There is a similar initiative already underway in Europe. This isn't about just performing a procedure. It's about a comprehensive approach to treating a disease that maximizes the chance of a patient getting the right procedure at the right place at the right time with the best possible outcome. Now, whether you're a fan of this all depends whether you're inside the fence or outside the fence. And obviously, if you're inside the fence, you think this is a good idea, but if your center's outside the fence, you don't think that this is a good idea. So the misconceptions that have been out there about this in the public comments, that it's all about TAVR and that it's an exclusive club and it will limit access to care. But it's anything but that. It's the idea of it's a rising tide floats all boats, and it's establishing standards that should be in place if you and your center wants to treat valvular heart disease. And if you want to put forth the investment in your center to become a comprehensive valve center, then the whole idea is that these are the tools to get into place to be able to achieve that. So the management of valvular heart disease, as I started, is significantly changing. In the past, I think it was this, and the present is this, and the future it's going to be this, and I think a system of care is something that should be seriously considered. Thank you very much.
That's a great summary of a pretty complex debate that's probably not going to end very quickly. Mario, next speaker going to tell us whether we should be routinely screening for leaflet thrombosis. Certainly something we need to know about.
Thank you, Adam. I'll make some advertisement for you. If you ever need someone to teach you how to do a transcaval TAVR, invite him. He's pretty good at that. All right. So Alan just told us how our advances helped us with TAVR, and then we seem to be good at just finding new things and new problems, right? And this is one of them. And the question that I should answer here is, should we screen for valve thrombosis, also known as HALT, or early hypoattenuated leaflet thickening? I think that's something that the imagers invented so that they have a role in the TAVR programs. Okay, but in all seriousness, they find it. So this is a typical picture. You saw it before, a TAVR. I think there's a screen here. Let's see. Otherwise, you see these hypoattenuated thickenings there on the CT. They can be in all leaflets. In one leaflet, seems that there's not really a rule to it. And I put this little table together. There might be more studies, but this is what I found quickly here. Just to, on the left, mention the authors. In the middle, the incidences. On the right, some factors that they put in their conclusions. And it seems that you see the highest is with 23% in 78 patients. If you look at the bigger studies, Resolve and SAVR, it's like 13%. Seems to hover around a 12 to 13% percentage that you see in your population. If you don't screen for that, that's what you're going to miss, because everybody shows these 12 to 13% probably. It seems like, for whatever reason, the balloon expandable valves show more thrombosis than the self-expanding valves. Interestingly, and that I think confuses some engineers at least, is that the bigger valves actually show more of that valve thrombosis. Again, small numbers, but it seems to be quite consistent. And it seems to be associated with your treatment strategy after deployment, because some of us probably already do Coumadin for 2 or 3 months, and some might adhere to the strategy of dual antiplatelet therapy or just aspirin, because there's really also no strict guideline. but it seems to be associated with. So if you're on a Coumadin treatment strategy, you have less of that, which is almost obvious then. So again, 12%, I just took the average out of those 5. Interestingly here, Dr. Pake, I think is from Germany, the third one, they just published also an article in JACC Interventions, I believe, not too long ago. And they analyzed their data for outcomes, and they call it medium-term outcomes, I think 406 days of medium follow-up. And the good news is they didn't see any significant signal towards TIAs or strokes. So there is this valve thrombosis, but it doesn't seem to accumulate in higher risk of stroke. That's the good news, but we still have to deal with it. Again, here's a summary, and this is from that larger Lancet paper here. It seems that the balloon expandable valve here Edwards mentioned is slightly higher than the Evolut or Medtronic valve, 6 to 14%, but you can also see it in surgical valves. So I think that's what I would criticize our surgeons, because we, of course, did all these CTs now and actually very thorough follow-up. We don't know what it was, 5 or 10 years ago, and maybe our surgeons could comment on it. But the Magna valve showed a signal here in this study. Interesting questions. So possible mechanism, Dr. Dangas really wrote a nice review article here, and it seems to be this Virchow triad, right? So the surface factors, incomplete prosthesis, endothelialization, as some examples here, leaflet damage, and here comes, of course, the question, what if we do valve and crack these valves? Is that really long-term a good result? Because we're thinking about long-term here, right? So I don't know how you guys see it, but my patients don't want to have SAVR anymore, right? So they ask for TAVR, they will be younger and younger. So if we do all of these things, what does that really matter in 10 or 15 years if we have valve thrombosis? We shouldn't think about 5 or 8 years. We should be thinking long-term here. Hemostatic factors, no data. I mean, we just talked about it on our table yet. We have all these valve trials. Do we do any biomarker studies? No. I don't know why nobody wants to invest that to find out how phenotypes are actually playing a role in valve thrombosis in all of these outcomes. We're trying to get money. Nobody wants to give us some money. And then here, I just met Dr. Marwan in Vienna in a completely different setting. But they also wrote a little review article on the left shear stresses. There might be some interaction with clopidogrel in certain patients. But again, we could test that, right? We could find all about it. We just have to do it instead of just implanting thousands of valves. We should start thinking and measuring things, right? So put a bug in your ear. So one of our fellows, I don't know if he's still here, Michael, he did a nice study on actually pacemakers after TAVR, and what he found that there was actually a quite significant subclinical atrial fibrillation incidence. So when you look at the pacemaker analysis down the road, and you don't rely just on your clinical assessment of EKGs or asking primary care physicians, you actually find a good number of patients with atrial fibrillation, and guess what? It's about 15%. I'm just wondering, is this just a coincidence in numbers, or is there some sort of phenotype in patients? Maybe that is part of the anticoagulation or coagulation pathway in some patients, that they have unknown AFib and it settles down there. Just put it in your ear. So there's some trials, we heard about it, so I'm not going to spend a lot of it because there was already a slide on it. The Galileo trial, at least per website, is not recruiting anymore. The popular TAVI is recruiting, that's aspirin and clopidogrel versus oral anticoagulation and clopidogrel, and Atlantis with apixaban. I think those were, I agree, interesting outcomes, and see if we can reduce HALT. And as take-home message, I would say, since it is such a high incidence and prevalence, I would say yes, you should screen for valve thrombosis, especially if you're a balloon expandable TAVR center. It seems like there's not a lot of data on that, but if you look at the Lancet paper, in a few patients, they reported that 50% of them, it was maybe just 20 patients or so, but 50% had a recurrence rate. So if you treat them, you have to have a strategy of re-imaging them, I would say, because some of them will actually have HALT again after you stop your Coumadin or whatever strategy you're using. So I think after 3 months, it's not over yet, so there's more data to come. And then there's these signals for balloon expandable, and then for whatever reason, larger valves at this point, and it seems like if you have an anticoagulation strategy, you're doing better there. I have no idea what it means long term, but I have my suspicion that all of these little things that we're finding are what determined the early degeneration in these valves, in surgical valves and TAVR valves. And I think we need to have, when we do all of these nice trials, we should have sub-studies where we do a really advanced biomarker study as well for phenotypes. And I hope that that's going to happen soon. Thank you very much for the invitation.
Thank you, Mario. We're going to move on now to Jeff Popma talking about underperformance criteria to establish proof of durability. Jeff?
Great. Thanks. Those are great presentations, and I'm really happy to give this talk. I have to say that when I saw it on the schedule, I thought, oh boy, this is going to be a real snooze. Because really, when you think about the concept of performance criteria and valves, it's a little bit different in terms of what we do in our usual practice. So let me get out of Alan's. That was a great talk. I thought I'd just repeat it for you. Before I really get in big trouble, how many? I know Mike and Mike. Are there any surgeons here? Any other surgeons? Okay, one. Okay, we got one. Okay, got one in the back. Good. So if I say anything offensive, I just want you to beat me up in the midterm. So that's all right. The real question that we always debate every day in our clinical practices is the patients say, how long is the valve going to last? And when you say something back like, I think it's going to last from what we know 5 to 10 years, there's a little bit of disappointment on the patient's face because they think, it's only going to last 5 or 10 years. Well, no, that's the only thing that we really know. And the truth of the matter is that when we look at the preclinical testing that goes into both surgical and to transcatheter valves, it's a very complex durability analysis. It's a finite element analysis which shows where there's stress on the posts and the leaflets. All the valves, the leaflets themselves go through 200 million cycle testing, 5 years, 600 million cycle testing, 15 years on the frame, and all of the preclinical requirements have been pretty rigorous to get us to the point where we actually implant valves into patients. Now, the criteria for the surgeons and surgical valves was really developed in 1994 and published in 2001 using optimal performance criteria. And those OPCs were related to several complications associated with surgical valves. That means no randomized trials, just following the patients for a requisite number of patient years. And if you focus on the right side of the screen and look at the OPC frequency rates, thromboembolism, valve thrombosis, hemorrhage, paravalvular regurgitation, all of those are under 3%. And as a result, the performance criteria were that there had to be collected a number of patient years with each of the valves. So 200 patients for 10 years is 2,000 patient years in order to know what the frequency is so that it did not exceed 2 times the OPC. So when it comes right down to it, the only valve complication that we're worried about now for surgical valves, of course, valve thrombosis. And in order to be certain that surgical valve thrombosis did not occur at 2 times the OPC, there need to be 4,800 patient years, and that's pretty hard to get for most of our studies as they walk through. Now, what I think is amazing and interesting vis-a-vis our discussions now is the fact that there's no hemodynamic requirements for the OPCs. These are all major complications. Now, this was really raised by Dr. Starr in a very provocative editorial in 2006. He admits that the FDA requires randomized trials for new drugs, but none of the surgical valves ever required a randomized trial for their approval. And I think there's probably good reason for that. But here are the outcomes that surgeons have talked about with respect to structural valve deterioration. It's reoperation and surgical explant. And those rates are around 2 to 15% at 10 years. So it's the big deal, right? It's not you have an echo, you come back, you see the echo gradient's high, it's structural valve deterioration, which is what we think about in the TAVR world. It's actually that you had to take the valve out, or you had to do a reoperation or TAV and SAV. Now enters into the world, and I just use core valve as an example, enter as a transcatheter valve. And a transcatheter valve that was specifically designed to have a superannular location and lower gradients than an annular valve that's placed with the surgeons. And then Mike has published this We're now out to 2 years. Tom Gleason at TCT this year is going to do 5 years. But for each of the time points that's measured, the hemodynamics of the core valve are better than the hemodynamics of the surgical valve. All the way out now, we'll see at the 5-year data coming up as well. And so the real provocative question, I think, is title of the talk is, do these lower gradients that we see with transcatheter valves compared to surgical valves translate into a lower rate of structural valve deterioration? And should we use acute hemodynamic criteria to be incorporated into our structural definitions? Well, VARC2 raised one of these. The VARC2 was a group of very prominent interventionalists and heart surgeons and non-invasive cardiologists who sat around together and said, let's come up with our criteria in order to decide what was actually valve failure. And in the VARC2 criteria, it was normal for stenosis, mild stenosis, not really using the words deterioration, and then moderate to zero stenosis, simply using the gradients or the effective orifice area. And the problem for this very, very complex matrix is that sometimes there was a discordance between a gradient and an effective orifice area. And that would be, as an example, the mean gradient was 6 millimeters of mercury, but the effective orifice area came out to be 0.5. And it happens all the time, and you don't know what to do. So here's the solution. On the right side of the screen, how do you get through this matrix? Right, this is the matrix of how you evaluate for structural valve deterioration in patients who have a discordance between the gradient and the effective orifice area. And I'm still trying to get our echocardiographers to take out the effective orifice area index out of the reports because it always looks bad. Well, obviously that's not going to be a gradient, that's not going to be an algorithm we're going to easily be able to walk through. And so the group in Quebec came up with something a little bit simpler. And they said, okay, let's come up with some criteria for structural valve deterioration. And let's just say that a mean gradient more than 30 means something bad happened and the valve's not working normally. Now, it doesn't have to be replaced, just as a mean gradient more than 30, along with an effective orifice area of under 1 centimeter squared. Then to go to lesser degrees are down to 20, and they put this into 2 categories. Possible structural valve deterioration where the transcatheter gradient went up by 10, and clinically relevant where it went up by 20. Well, how did they get that? They sat around the table and said, what do you think sounds right? Is it reasonable? And it sounded pretty good, but it actually didn't have much prospective validation. But they did identify a bunch of factors that led to these higher gradients, and it's very important. Some of them related to the patient's age, some of them related to their cardiovascular morbidities, and a lot of it related to valve-related factors like the prosthesis size, and most importantly, the size of the valve compared to the size of the patient prosthesis mismatch. And then there was light. In December of 2017, the European consensus document was published and provided us definitions about how we're going to put the surgeon's definitions of valve failure requiring reoperation and our hemodynamic criteria of saying when we're worried about somebody in the office when they have a 25 millimeter gradient a month after TAVR, and saying how are we going to put those 2 components together. And what they put this into different structural categories. One is structural valve deterioration. Something's wrong with the valve, it's leaking, it's dysfunctional, the patient's symptomatic, needs to come out. Then there's non-structural valve deterioration, which importantly includes the hemodynamics. And I'll go through a little bit more detail about what hemodynamics they've used. But I think very importantly, they've added into these definitions for bioprosthetic valve deterioration thrombosis, because that's something that we all need to be thinking about when we see a patient in the office a month or 2 after they've had a transcatheter heart valve and their gradient is high. We have to think about thrombosis. And then, of course, the infrequent episode, less than 1% of endocarditis. Now, this is a small on the top, but I'm going to read through this because Danny's not here, and I think it would be great if Danny were here because he could discuss this. But in the TAVR world, looking at the farthest outcomes that we have, which are out to 5 to 9 years, the rate of structural valve deterioration using the standard criteria is under 2%, except for one study, and that was Dr. DeVere's study, where he captured patients who were in the early experience out to 10 years and found that there was a 50% rate of structural valve deterioration. But the math is actually very well delineated in the consensus document, and that's a problem of a competing risk. And that is that if everybody lived out to 20 years, you could exactly tell what the rate of valve deterioration would be. Problem is, in the patients we're treating, they don't all live to 20 years. And so in this series, most of the patients died. Less than 20% of patients were still alive, and so there was an overestimated sort of frequency of structural valve deterioration due to competing risk. And that's something we need to be very thoughtful about. So what do we need? Well, Dr. Reardon is leading the Versatility trial, the low-risk trial. We're following all the patients now out to 10 years. That's what we need. We need a lot of patients out to 10 years to be able to see exactly what our rate of frequencies are going to be. Now, in this article, in this consensus document, I think it was brilliant, there were 4 guiding principles about structural valve deterioration. The first one was you have to differentiate from the patient who has to come back and have another intervention with those patients who have hemodynamic criteria in the echo lab of who's doing poorly that you have to watch them more carefully. That's the first one. Differentiate between the structural valve deterioration, which is simply a gradient, maybe at higher risk for something happening, and those that really have bioprosthetic valve failure. That's point number 1. Point number 2 was that the deterioration sometimes is irreversible. So if you get pannus, if there's a leak, a torn leaflet, that's going to be irreversible. But some of these are reversible, and we have to think about that when we see the patients in the office. And if a gradient pops up out of nowhere, you have to think about this. Leaflet thrombosis, you have to think about endocarditis. Third principle. The fourth principle is that non-structural deterioration, late embolization, may occur after TAVR because of technical issues, specifically patient prosthesis mismatch. And that what we really need to think about now is what we would have expected as the valve gradient after a series of valves we do, whether we use balloon expandable or self-expanding. Let me give you an example. This is a very provocative analysis done by Becky Hahn, which put the Edwards group together with the Medtronic group, Sapien and Core Valve, and it looked at the quintiles of gradients, and let's look at the smallest annulus size. The smallest annular size had a 14 millimeter gradient with the smallest annular size, and a 9 millimeter gradient at the largest annular size. So we can also get prosthesis patient mismatch with our balloon expandable valves. In comparison with the self-expanding valve, the hemodynamics were a little bit better. We didn't see that same prosthesis patient mismatch effect in this, and maybe that suggests that we have to think about the hemodynamics, but we shouldn't be too concerned if we know that we've put a 23 Sapien in and we have a gradient of 12. That doesn't mean the valve's deteriorating. That's the expected ppm. And I think these values are going to be very important for us to understand the size of the valves that we've actually put in place. And the fourth one is that echocardiography is going to be key for evaluating this. Now, I would say that the echocardiography is going to be extremely important to determine who has structural valve deterioration because of the Notion data 5 years. Notion was an all-comes trial. Lars Sundergaard was the principal investigator. These patients were all followed with echo out to 5 years. Much better gradients for the transcatheter valve, core valve, than with surgery. But using the criteria of moderate structural valve deterioration in the European guidelines, the frequency of moderate structural valve deterioration was 26% with surgical valves and 3.9% with transcatheter valves. So what I would conclude from all of this when I talk with my patients is we don't know what the long-term outcome is, but I think we're okay compared to surgical valves. But we need that 10-year data. So what do we conclude as take-home messages? Well, these performance criteria that we can come up with gradients, they've been a historic pathway for surgical approval based on the metrics. But the metrics that have been used for surgical valves were really major complications, reoperations, thrombosis, endocarditis. What we are now moving towards is understanding the early hemodynamics of these valves. And it looks like it may predict long-term outcome, but it's way too early to establish that as definitive. These small differences in the gradients may not translate into differences in clinical outcomes. We need to learn that. Randomized trials for device approval are not the answer. What the answer really is going to be, we have to follow our patients out to 10 years or longer, particularly in healthier patients, to avoid these issues of competing risk. I think the European guidelines are awesome. I would encourage you all to read them. I think they're phenomenal. They put together the complex issues very succinctly. But most importantly, the SAVR valves and TAVR valves performance are under increased scrutiny. For example, for surgical valves, how many in the office follow the patients every year with an echo and gradients? Never, right? I don't even get it, typically don't get a surgical valve echo again, unless they clinically something changes. So now the scrutiny is going to be different. I think we're going to learn a lot as we move forward with the definitions of structural valve deterioration. Thanks for your attention.
Great job, Jeff. It's now my honor to introduce my co-moderator, Dr. Reardon, who's going to tell us if we're actually undertreating valve disease in the U.S.
Well, Jeff, that was a great talk, and I think the thing that everybody always forgets is that it all has to do with your age. We talk about these as degenerating at the same rate. My patients come in and say, how long will they last? And the first question is, how old are you now? So I was assigned the topic, is there a problem with undertreatment of aortic stenosis? Let's see if we can get this. My disclosures, I'm involved in a number of the trials. I don't think it really is going to involve what I do here. So a couple of questions we need to answer in this talk. One is, what's the incidence and prevalence of symptomatic aortic stenosis in patients over 65? And I'm going to stick with slightly older patients right now. I'm not going to look at the entire population because it's really kind of what involves those of us that are doing TAVR. We want to know, is it underdiagnosed, and what this might mean for surgical valve replacements in the future and TAVR volumes in the future. So the incidence is how many people per year newly acquire the disease. The prevalence is how many people have had this disease during this time period that we're looking at. Now, this is from the Mayo Clinic. This is looking at the prevalence of valve disease, both in the general population and those in Olmsted County, where the Mayo Clinic is located. And you can see that as you get older, your risk of aortic valve disease and mitral valve disease go up. Mitral valve disease is actually more common than aortic valve disease. Aortic valve disease gets treated more commonly. And if we look at how often it occurs with people that are 65 to 74, it's about 1.4% have severe aortic stenosis, and over 75, it's about 4.6%. So if you kind of blend these together and you say that in 2016, there are probably about 49 million people that are over 65 years of age. If we say at 2%, that's about 490,000 cases of severe aortic stenosis. Now, one of the problems we see is that our population pyramids used to look like a pyramid. It would start with young people, and they would actually taper down to about 20, and then it would stabilize a little bit, and then they would start surviving for a while because all the young people died of strange things or trauma or things that young people do, and then it tapered over time. Now we're getting a column. People just aren't dying, and people are getting older and older and older. So people have looked at this, and there's a really good paper that came out of Peter Capitan and Nick Van Meegen's group at Erasmus, looking at the annual number of candidates for transcatheter aortic valve implantation per country in Europe, but it's going to be fairly similar to here. And so what they did is they started with a general population over 75 years of age. They looked at, in Europe, an estimate of how many people would have severe aortic stenosis, which would be about 3.4% of those. They looked at those that were symptomatic versus asymptomatic, and they're about 3/4 symptomatic and 1/4 asymptomatic. Asymptomatic, no TAVR. If you're symptomatic, some of these were going to get surgery, about 40% in Europe at that time, and about 60% were going to get, 40% were getting TAVR, 60% were getting surgery. And if you're going to get treated with TAVR, some of these were only medical managements because they're cohort C, and they could kind of taper down at each way, which how many people would likely be needing a TAVR. And they would estimate the TAVR per year for the US using this and for Europe. And based on adding intermediate risk, which we have added now, there should be about 51,999 TAVRs a year done in the US. If we add low risk, assuming the two low risk trials, which I expect to both be presented next year, are going to be positive trials, which I think is very, very likely, that gets us up to about 80,000 that need to be treated. So this was the STS ACC TVT registry as of 2017, 47,779 TAVRs. So we now had more TAVRs than aortic valves. Aortic valves are going down a little bit. It's clearly not a zero-sum game. But if we added intermediate risk, it would move it up to this. If we added low risk, it would move it up to that. So you can see that the number of TAVRs that we're likely to be doing are going to be really increasing. I didn't change the surgical numbers because I didn't really have a way to do that. They're probably going to continue to dip, but they're not going to go completely away. Now, if we look at the people out there, this was quoted to you earlier, this was Vino Thorani's paper, looking at the STS and looking at where you people sat. If high risk was defined as an STS over 8, that was about 6%. Intermediate 4 to 8, that was about 14%. And low risk was about 80%. Now, Adam and I were talking, these numbers probably don't, STS numbers don't probably really correlate with which is high, intermediate, and low anymore, because the STS changes every year. It's probably actually lower numbers than that. If you look at Denmark and how people are treated in Denmark by risk level, 100% of the high-risk people get TAVR. About 68% of the low-risk people are getting TAVR, and about 9 or 10% of the low-risk get TAVR. So if you look at underdiagnosis, this was a study that was done in England. They looked at 2,500 people that were over 65 years of age. They were seeing a primary care doctor. They had no diagnosis of valve disease. They got echoes on these people, and valve disease that was undetected previously was found in 51% of the respondents. 34% were these were just aortic sclerosis, 22% were mitral regurgitation, 15% were aortic regurgitation. But aortic stenosis at a significant level was presented at 1.3% in completely previously undiagnosed populations. And what you found is as you moved into the kind of lower social economic portions of the patient population had less access to health care, and the number of new valve diseases were increased. So they could estimate in the UK what was going to happen with the diagnosis of aortic stenosis. The diagnosis of aortic stenosis was going to go up over time because the population was getting older, but the underdiagnosis was significant. It was at least 100% underdiagnosed in the UK. There's very little reason to assume the UK is going to be different than the US. In fact, this has been estimated at the US, looking at on the left what is the current prevalence, about 300,000 a year, as to what we really think it probably is, which is about 650,000 per year. Now, I remember when we started the high-risk and extreme-risk core valve trial, I was talking to my interventionist colleague, Neil Kleiman, and Neil said, well, we won't get any extreme risk. And I said, why, Neil? He said, because everybody I see, I send to you to operate on. And then we started extremists, and all these people came in, and Neil looked up and said, where are all these people coming from? I said, Neil, they never sent them to you because they didn't want you to send them to me for surgery. They're out there, we just don't know about them. But it's not just extreme risk. There's high-risk people and intermediate-risk people, and even some low-risk people that have told their docs, I just don't want to see anybody. But as less invasive therapy than my surgery comes available, they're going to show up. And there's a lot of people that are asymptomatic in the elderly. At least you think they're asymptomatic because they tell you nothing's wrong because they really aren't doing much and they just don't want anybody to know. But the conclusion of this was that a lot of these people really are symptomatic if you look at them, and they really do meet all the guidelines for having their valve repaired. And if you don't treat these people, the event rate is extremely high. So aortic stenosis really is underdiagnosed. TAVR is likely to markedly increase with time, and I think surgery will moderately decrease. It's not going to go away, but it'll decrease to a certain amount. Is there a problem with undertreatment of aortic stenosis with TAVR? That's a resounding yes. Thank you very much.
Thanks, Michael. Last but not least, former colleague, Dr. Cavalcanti, going to tell us about the future of imaging.
All right, so I'm the only one separating you guys between lunch and the session, so I hope to be brief again. Really honored for the opportunity to present on this topic, and we have been hearing a lot about the valve disease and the implication of how to fix these valves with TAVR. I'd just like to take a step back and consider how we should also consider the other component of that, which is the myocardial disease related to valvular heart disease, related to aortic stenosis specifically. We have come a long way to understand that TAVR now has become really predictable. We do that with CT, we get measurements with selected patient prosthesis, we select how we're going to get to the valve, and this is now a pretty piece of cake. I would like to now wear my other hat here with the CMR, which is an untapped and I think an unmet need, in which we need to consider and better understand where do these patients fall into the spectrum of disease. CMR can look at the valve, can look at the ventricular morphology, can look at the remodeling and track response after intervention. We can look at flow and velocities. We can assess also myocardial ischemia with the coronary artery disease, which is prevalent in these patients. We can look at the 3D anatomy without the need of contrast, which could be quite advantageous for patients with advanced chronic kidney disease. We can also understand better about the tissue characterization. I think that's where CMR can shine, is the ability to measure, not only to look at it and to recognize, but also to measure myocardial fibrosis, SCAR, with late gadolinium enhancement, as well as this new kit called the diffuse interstitial fibrosis, which is something that I'm going to elaborate over the next couple of minutes. So let's take a step back. This goes almost 30 years ago. This was a bicuspid severe aortic stenosis patient that underwent autopsy, which we don't markedly do nowadays. But as Van Hoven had shown in this slide, is that he highlights here, the myocardial architecture is a reminiscent of cirrhosis on a low power. We talk a lot about interstitial liver disease, interstitial lung disease, But aortic stenosis creates interstitial heart disease. And that's what we're dealing with. We can fix the valve, but at times these patients might feel better, but the recovery is not complete and not uniform. Taking a look from electron microscopy, we can see that there is myocyte hypertrophy and also interstitial expansion, which is depicted here on this red arrow. The good news is that what has limited us to measure that diffuse interstitial fibrosis now is capable of being done non-invasively with the use of CMR. These are two separate studies, two separate groups showing that the correlation by invasive biopsy against CMR is actually quite good. And we could take this measurement, which requires gadolinium and special sequence, that we can measure how much is that interstitial expansion. Is that important? I would argue that it is. Let me take you through this slide here from the group from Edinburgh. We have three groups here. Once we can measure that, then we can separate them into three tiers. The first tier would be patients with no fibrosis by late gadolinium enhancement, no interstitial expansion. The second tier, patients with interstitial expansion, but no fibrosis yet. And obviously the third one, which would be fibrosis and interstitial expansion. There is actually a dose-graded response. The more abnormalities in which one of the compartments you have, the worse the outcomes. And you could say, okay, that kind of makes sense. And you're saying, well, maybe how good is your measurement? Because I can see here, the more stenosis you have, the more fibrosis you would develop. And how good it is your measurement because you have tons of overlap. How can you differentiate between moderate and severe? I'll draw your attention to this dashed line. This is where the interstitial expansion exists. So a patient that has severe aortic stenosis here to the far right, you could have a patient that has no interstitial expansion, no fibrosis. That could be potentially a patient that we could consider, you know what, watchful waiting might be okay for you. Whereas this patient here that has moderate aortic stenosis has already interstitial expansion and perhaps fibrosis, in which waiting too long might be not of his benefit. This is a paper that just came out this past week of Circulation. We have an upcoming editorial with Dr. Suraj as well, looking at the very large cohort of about 674 patients. This is the largest registry of CMR. All patients underwent CMR before aortic valve intervention, be that SAVR or TAVR. And what they've shown is that it doesn't matter how that fibrosis got into the myocardium, whether you have infarct-related fibrosis or mid-wall fibrosis from just the ventricular hypertrophy, it doubles your mortality. It triples your cardiovascular mortality. And that is both for SAVR or TAVR, and it doesn't matter which type it is. And it's not only a binary, yes, you have fibrosis you don't have, it's actually the amount of it that you can quantify that does also matter on a multivariable analysis. The concept that we're working now, the framework with the group from Edinburgh, is that perhaps are we intervening too late? Are we waiting for the fibrosis? Are we waiting for the symptoms to develop so that we can pull the trigger and say, intervene now? One way to consider that is that after aortic valve replacement, that replacement fibrosis scar is not going to disappear. You're going to stop the process, but it's not going to disappear. Whereas the ventricular remodeling, however, actually can be reversed. A watchful waiting approach, and this is a series of scans that we have been doing in our center collaboration with Edinburgh, has shown that fibrosis actually progresses. Once it installs there, it's actually only going to go one way, and it does not disappear. The other phenotype that we have been looking into as well is this other of cardiac amyloidosis. So now we have two aging processes, right? One is calcific aortic stenosis, and the other one is senile cardiac amyloidosis. Actually, this overlap is not uncommon. 16% in 3 independent series. This is 1 in 6 patients, so that's not rare at all. Who are these patients? Predominantly octogenarians, low flow, low gradient, predominantly male, and you can see by these Kaplan-Meier curves here that the separation exists and occurs very early on, and it did not matter whether they got TAVR or not, the mortality was worse. And by CMR, you can see that they are markedly different. This is a patient with severe AS, no fibrosis, and a patient with marked interstitial infiltration, both on the right and the left, and even the left atrium here to create the atrial fibrillation. So if we understand that these two categories, these two phenotypes are completely different, patients with AS and cardiac amyloidosis and patients with pure aortic stenosis, and we measure their interstitial expansion. Normal ECV for us here should be around 24%. The AS folks have more ECV, have more interstitial fibrosis, but look at the amyloid. They're a completely different one. So let's take them out. Let's just look at the aortic stenosis patient, and you can see there is a dose response. And that makes sense. The more fibrosis you have, the worse the mortality. But I would like to draw your attention to there's actually a black line. This is, despite severe aortic stenosis, there was no mortality at 1 year. So we can probe now the myocardium and see where exactly do you fall into that curve, and perhaps that should inform a decision. The good news is that how to scale that, because not every center has CMR capabilities or access to that. Perhaps we could consider that by using CT. You're required to do a pre-scan and a post-scan, and actually there has been some good validation with invasive biopsy as well as against CMR, and this is a work in progress by showing that it can detect interstitial expansion on aortic stenosis as compared to patients with amyloidosis. So ladies and gentlemen, in the context of TAVR, I think CMR might be a very important player that we need to consider. Aortic stenosis is a disease not only of the valve, but the myocardium, and I would argue that also of the vasculature, of the vessels. And we're going to have a next chapter on that. Watching for just LV ejection fraction changes is old news, and I don't think it's enough. Fibrosis is what we should consider, and we have methods to measure that. Should we consider to intervene even before its development? When should we consider? Should we wait for symptoms? In cardiac amyloidosis, it's not uncommon, and I think we need to recognize that. And it brings the question, should we consider pre-TAVR screening? And with that, I'd like to conclude and take questions. Thank you very much.
Well, Jacques, quick question for you. So are we just picking up a marker of poor outcome, meaning they're true unrelated, or is there a link between the aortic stenosis and some of those findings?
Yeah, I think this is a great question. In terms of the link between AS and cardiac amyloidosis, there's definitely a biological link. Actually, autopsy studies have shown, and even resection of valves have shown that actually there's amyloid deposition on the valve tissue leaflets itself. So in the turbulence itself of the valve, just the jet stream also precipitates the deposition of that. So, and now this field is going to explode because therapies for cardiac amyloidosis are just coming at the corner now. They just had new drugs approved for neuropathy-related cardiac amyloidosis, and they're testing that. So I think it might be considered a two-pronged approach. Should we treat the valve, and should we treat the myocardium? Should we wait for the valve to become severe to treat that? It's fascinating, but it's really not uncommon.
John, during your talk, about 1,000 lights was going off in my head over there, and because I do think I struggle with these patients all the time in the office about what to do, because, you know, they're elderly, their ventricles are thick, they have like no symptoms that you can get out of everything, their gradients are high, and we just wait. And is there a standardization of the methodology for cardiac MR such that I could send them to Warren Manning and say, look, do a cardiac MR, and if my number is above 8% fibrosis, we should think about doing this to stop this irreversible process. How close are we to, I'm ready to go back and order tomorrow. So how close are we to be able to implement this? Because I think it's phenomenal.
You know, I really appreciate, Jeff, your enthusiasm, and I would like to share that this is actually quantifiable. The sequence has been described since the mid-90s and really proven to be there. What I think it has to be recognized is that, you know, image quality is dependent on a scanner and how you play with the sequences, but we can do this on a reproducible manner, in a much better way that we can predict. Now, what is the threshold by which, you know, we will have this inflection point that would say, beyond here, you should intervene or not? We still don't know. I think this very first paper that just came out last week, as I mentioned, circulation, is quite important. By the time these patients get intervened on, a lot of them have fibrosis, almost 50% of them. And actually, the non-ischemic is twice more prevalent than the ischemic.
Wow. Wow.
So these patients don't have coronary disease, but already they have ventricular suffering. So
we should do a registry or something. Are you going to put together a multi-center registry?
Yes, I think that's something that we would need to discuss amongst, you know, many of the other vendors. I think this is an incredible opportunity. And the good thing, Jeff, is that the reproducibility of CMR is so good that we don't need 500 patients. Yeah. You know, it's reliable. So
yeah.
You know, it is interesting because, you know, what imaging is continuing to teach us. When I started doing aortic valve surgery, which when I went into practice in 1985, I looked at an echo and I looked at the patient. That was all imaging we did. Maybe we could operate. You look okay. You know, come on in. And I look back at all the mistakes I know I've made because of inadequate knowledge. So we have a few minutes left. Any questions from the audience for the panel? Yeah, Onkar.
Just wanted to build up on the discussion we're having about low flow, low gradient, severe aortic stenosis patients. They don't do well at 2 years, irrespective of how we screen them. I think the screening of choice is a dobutamine stress echo. and you demonstrate that there is systolic reserve or there is absence of systolic reserve, and you still go on and do the TAVR if the valve area, it remains the same and the gradients go up, but they do poorly at 2 years. So is MR the diagnostic modality of choice in screening them? And like Jeff said, is there a quantifiable interstitial myocardial fibrosis number beyond which we would say, you know what, this is a poor substrate, myocardial substrate, we should not offer them TAVR? And then I would extrapolate the same question to another confusing group, which is paradoxical low flow, low gradient severe AS, which is another conundrum. I mean, some groups have described that you shouldn't do anything at all. But we see a lot of these patients in our practice, so I wanted to pick your brains on what you think is the best screening modality. Thanks.
Yeah, that's a phenomenal question. So I can break it down in two boxes. One would be the low flow, low gradient with low EF, and the other one would be the preserved EF. So using, again, EF as the metric, all right? So the low flow, low gradient with low EF, there has been actually a lot of developments in that sense. I think, recently we published the TOPAZ TAVI showing that the dobutamine stress echo, it's good, but the flow reserve or contractile reserve does not predict outcome and does not predict who is going to improve LVEF. So the message there is that don't stop. Even if you don't have flow reserve, the patients do better if they treat. Now, the mortality might be quite high because it's tons of fibrosis and the opportunity to learn there. Avoiding the topic that I talked about the first talk, the dichotomania, I don't think we have yet that threshold by which beyond here you should do or should not do it. For the paradoxical low flow, low gradient, I love that slide that Dr. Holmes had. It's a mixed bag. And concomitant valvular disease, it's very prevalent in these patients, AFib, pacemaker, dysynchrony, and amyloid. I think the amyloid is the one that falls under the radar screen. A lot of these patients have low flow, low gradient because the ventricle is just doing that, right? So, and they don't have enough flow.
Mike can maybe chime in as well, but in the core valve study, we did those patients in our pivotal IDE trial that augmented to dobutamine, right? So we did those patients, and if you pounded their ventricles with 20 mics per kilo of dobutamine, you got their gradients over 40, we said, okay, you've got contractile reserve, you're in. And then along with that, we did an expanded use registry where we included patients with low flow, low gradient, those who got dobutamine and didn't augment, and those that had ejection fractions. That was our normal ejection fractions. And who did the worst of all of those? The patients who augmented with dobutamine in our high-risk trial. Completely opposite of what. So we sort this out a million different ways. But the TOPAZ study, I thought, was finally we had some validation that when we use dobutamine, as Dr. Holmes used it earlier, to find pseudostenosis, find people whose gradients don't go up very much, their valve area goes up, they need CRT, they need something else. But we have been treating patients that don't augment with dobutamine when their gradients are 25 to 30 or so, and they look like they have an ejection fraction of 25%, and it doesn't get better with dobutamine because we're completely confused about the role of dobutamine in that patient. Mike, do you understand the data?
I think the role of dobutamine is changing a lot now. I mean, I used it surgically for other reasons. So, obviously we would start off by trying to rule out pseudo-aortic stenosis, but then when we decided they had real aortic stenosis, if you have low EF, low flow, severe AS, and it's really severe AS, and I operate on you, your mortality is higher than if you have high gradient. If you don't augment, your mortality is huge. It can be up to 30%. And so I used it to screen out people that I didn't want to operate on. That doesn't happen in TAVR because we don't hurt them as much. Right. The other group of patients that we've learned a lot about that I find interesting, because again, I look back over my career and I see all the mistakes that I've made because we didn't understand it the way we're starting to understand it now because we look at it so closely, was the little old lady with paradoxical low flow, low gradient, because about half the time they'd come to surgery and you would open them up and their valve really wasn't that bad and they had about a big enough valve for a 19 millimeter valve and you weren't going to make them any better. And they're the ones that came off on onotropes and got a balloon and just faded away and never got better. Right. Whereas these people also do very well with TAVR because the hemodynamics, which you're talking about, are so much better than the surgical hemodynamics unless you do a stentless root or you do a valve enlargement or something like that.
But I think that's an important point for everybody is that, at least in the TAVR world, we don't seem to be hurting them. I mean, maybe they don't do as well as other subgroups, But sometimes they get a little bit better. You still struggle
Yes.
with diuretics and beta blockers and things, but we don't seem to be hurting them. And so this may be an issue of where's the futility point where you don't do anything, but I wouldn't want the message to be that, if you see any evidence of low flow, low gradient and any of this fibrosis, that we shouldn't do anything.
Yeah, I mean, the point is well taken because we're looking from one metric, which is mortality. For them might be quality of life with some improvement. I would argue that, a lot of these patients, particularly the amyloids, the personal experience is that they don't tolerate even mild PVL, mitral valve leak. It's a ventricle stiff, and so you're better off with valves that don't cause pacemaker or PVL. So that would be a prosthesis choice. I have a question for Mario, actually, on the prosthesis, the valve thickening. Some of the discussion that we had a few weeks ago about use of warfarin, and warfarin actually in some animal models and even in humans associated with vascular calcification and valve calcification. Is there a concern there? I mean, how would you consider that? Because it does not come, there's no free lunch. So I mean, yes, it might reduce the leaflet thickening, but you might be calcifying as well.
Yeah, I think if you do it long term, right, and that's the question, how long do we have to do it? I know that, established surgeons, I trained at Mayo, Dr. Schaff was always saying we should do anticoagulation for all prostheses once they are developed. I think they even don't do it. But if you do 3 or 6 months of warfarin after a TAVR, I think you will have a much lesser number of patients who have this thrombosis. And I don't think that you have to do it long term in all of them. But we still have to investigate how many have a recurrence of it, right? Mm-hmm. And I bring this up again because I really am passionate about it. I think we just don't know enough about phenotypes in these patients. We just implant valves, and retrospectively we try to figure it out. And I don't know why none of these valve companies is investigating it from a phenotypical standpoint. So, but I think long-term warfarin shouldn't be the goal in TAVR patients.
Well, I know Hartzell liked to anticoagulate, but one of the reasons I quit doing it was because I read the Mayo papers that said it didn't make any difference. And so, it's kind of interesting. We're going to have to wrap it up. I just one final comment. I think one of the takeaways here is one of the things we're all worried about is durability. And what do you tell patients about durability? And as Jeff pointed out, if you do Kaplan-Meiers, it assumes everybody lives for 10 years. And the average U.S. and Canadian aortic valve series is about 68 and a half years old. The average 10-year survival is 60%. So 40% of the people that are 68 years old are dead at 10 years, so their competing events are out. If you look at the TAVR studies where they're 83, it's not going to fall out. We're really going to have the low risk is probably going to be our first good opportunity to get this. What I tell people as a surgeon is that it seems to be tracking what we see in surgical valves so far. And if you're 80, you're good to go. So thank you very much for the session.